Scabies. Definition. Scabies is an infestation of the epidermis with the itch, mite, Sarcoptes scabii varietas hominis. Clinically, a few burrows are usually found and are diagnostic. Inflammatory papules resulting from host hypersensitivity, however, constitute the more frequent and obvious findings. Scabies, inflammatory crusted papules in a characteristic location. Incidence. Scabies is a common disease. It can occur endemically among school-aged children and may be hyperendemic among rural populations in less developed countries. Immobilized geriatric patients in nursing homes, patients with HIV, AIDS, and medically compromised patients, example, Down syndrome, are predisposed to infestation with high mite counts. History. Generalized pruritus is the major complaint. Scabies causes the worst itch of the patient's life, often severe enough to interrupt sleep. Frequently, a history of itching can be elicited in family members and other close personal contacts. The incubation time from inoculation to the onset of pruritus is usually approximately 1 month, so in early cases, other contacts may not yet be symptomatic. Because scabies also occurs in pets, canine scabies or mange. A pet history should be elicited, particularly in patients with recurrent disease. Note, itching is often severe enough to interrupt sleep. Family members and friends often also itch. Physical examination. Small inflammatory papules predominate. They are often excoriated. Scabies has a characteristic distribution with favored locations including the finger webs, wrists, elbows, axillae, girdle area, and feet. In addition, the male genitalia are usually involved. Scabies can present in a generalized distribution. Itching papules and small nodules on the penis should be considered the result of scabies unless proved otherwise. In temperate climates, the head is almost always spared in adults but may be involved in children. In infants, vesicles may also be present, particularly on the palms and soles. Scabies, papules on the head of penis. This is scabies until proven otherwise. Scabies, vesicles on soles in an infant. The diagnostic finding is a burrow, which appears as a 2 to 5 mm, delicate, white, serpiginous, superficial, thread-like line. The most common location for burrows is on the hands. With close inspection, a tiny black speck can often be seen at the end of the burrow. This black dot represents the adult mite, which is best visualized under the microscope. In some patients with scabies, particularly when the condition has been long-standing, scattered nodules may also be found. Scabies. Diagnostic burrow with a black dot representing an adult mite. Differential diagnosis. Because of the intense pruritus, in some patients, only excoriations are seen. In these patients, a misdiagnosis of neurotic excoriations could be made. Widespread disease may be misdiagnosed as other causes of dermatitis, including atopic dermatitis, allergic contact dermatitis, nummular dermatitis, and insect bites. The presence of burrows or mites and eggs under microscopy distinguishes scabies from these other diseases. Differential diagnosis of scabies. Neurotic excoriation, example, delusions of parasitosis. Dermatitis. Atopic. Allergic contact. Nummular. Other insect bites. Laboratory and biopsy. The presence of mites or eggs is diagnostic. This is accomplished by skin scraping with a number 15 blade. The highest yield is from a black dot at the burrow, but mites and eggs can also be recovered from papules and nodules. A biopsy is usually not necessary but may provide the diagnosis when it previously had not been suspected. Microscopically, one sees edema in the epidermis, which may be sufficient to result in a microvesicle. An inflammatory reaction occurs in the superficial dermis with lymphocytes and eosinophils. A fortuitous but diagnostic finding is the presence of a mite in the stratum corneum. Scabies mite. Epidermis, mite burrowed in superficial epidermis. Dermis, inflammation. Skin biopsy showing scabies mites in the epidermis. Therapy. Permethrin cream, Elamite, is considered the drug of choice. The topical agent must be applied to the entire body surface, including under fingernails. A single application of 5% permethrin cream is applied at bedtime from the head to the toes and is washed off in the morning. Some physicians recommend a single reapplication after 1 week, but no controlled studies have documented that 2 applications are better than 1. Permethrin cream is preferred for infants older than 2 months of age and for pregnant females. Treatment at the same time is recommended for household contacts. Those who are asymptomatic require only 1 application. Clothes and bed linens can be decontaminated by machine washing at a hot temperature. Oral ivermectin has been used successfully for treating scabies and has the advantage of ease of administration. A single oral dose of 0.1 to 0.2 mg per kg is sufficient for cure in most patients, although residual itching may persist for up to 1 month after this systemic treatment. Ivermectin may require repeated treatment in 1 week. Ivermectin is often used in outbreaks in institutions such as a nursing home. Oral ivermectin is not recommended for pregnant individuals and children weighing less than 15 kg, topical sulfur, compounded in petrolatum to 10% concentration. Can be safely applied for 3 consecutive days in a similar fashion to topical permethrin and repeated in 7 days. Therapy for scabies. Initial. Permethrin cream 5%. Alternative. Ivermectin, 0.1 to 0.2 mg per kg. Topical sulfur in neonates and pregnant individuals. Course and complications. When untreated, itching progresses and may become unbearable. After treatment, many patients continue to itch for 1 to 2 weeks. This possibility must be explained so that the patient avoids overusing the medication. Residual itching can be treated symptomatically with topical steroids and oral antihistamines. Nodules, if present, may last for 1 month or longer. Note, itching may persist for 1 to 2 weeks after treatment. Complications are uncommon. Secondary bacterial infection may occur in excoriated skin. In immunocompromised patients, such as those with AIDS or lymphoma, patients with Down syndrome, and debilitated patients with neurologic disorders, scabies may appear as a widespread, crusted eruption that often does not itch. This uncommon variant is called crusted scabies, Norwegian scabies, and is easily misdiagnosed as eczema or psoriasis. On close inspection, however, burrows and mites are usually numerous, and their presence confirms the diagnosis. Crusted scabies. Crusted plaque with a high mite load. Note, crusted scabies occurs in immunocompromised and debilitated patients. Pathogenesis. The discovery in 1687 of the itch mite made this parasite one of the first causes of human disease to be identified. The S. scabia mite lives in and on human skin, where it completes its life cycle in approximately 2 weeks. The impregnated female burrows into the stratum corneum, where she lays 2 or 3 eggs daily for as long as 30 days. Each egg produces a larva, which leaves the burrow and molts to produce a nymph. Several further moltings result in a mature mite, which then mates. After mating, the male dies, and the female completes the life cycle by burrowing back into the stratum corneum. Secretions from the burrowing female might cause intraepidermal edema fluid, on which she feeds. The itching and inflammation are thought to be a result of a hypersensitivity reaction by the host to the foreign material, mites, eggs, and feces, in the skin. This may account for the persistence of the itching for 1 to 2 weeks after successful treatment. It may take that long for the stratum corneum to turn over and shed the foreign material, and for the hypersensitivity reaction to subside. Here are a few practical tips. 1. It is difficult to transmit scabies through fomites such as bedding and clothing. Human-to-human transmission is most common. 2. The incubation time from inoculation to itching usually is approximately 1 month. 3. If left untreated, the disease course is one of progressively worsening itch. 4. Previously infested individuals are more difficult to reinfest, possibly because the hypersensitivity reaction is partially protective.
Clinical case. A 28-year-old man presents with intense itching for the past 3 weeks, which is worse at night. The itching initially started on his wrists and has now spread to the interdigital spaces, waistline, and genital area. His wife has recently developed similar symptoms. On examination, there are multiple erythematous papules, excoriations, and thin, wavy, grayish lines in the interdigital spaces and flexor aspects of the wrists. Some lesions show crusting due to scratching. What is the most likely diagnosis? A. Neurotic excoriation. B. Atopic dermatitis. C. Allergic contact dermatitis. D. Nummular dermatitis. E. Scabies. Correct answer, E. Scabies. Explanation. Scabies is characterized by severe nocturnal pruritus. Typical distribution, interdigital spaces, wrists, genitals, waistline. Burrows, pathognomonic but not always easy to see. Close contact transmission, family members affected. Why not the others? Neurotic excoriation. Self-inflicted lesions without primary burrows or contagious pattern. Atopic dermatitis, chronic, relapsing eczema with flexural involvement, often with personal/family atopy. Allergic contact dermatitis, localized to contact area, often with clear exposure history. Nummular dermatitis, coin-shaped plaques, typically on extremities, without nocturnal predominance or contagion. Thank you for your attention.